Good evening, everyone, and thank you all for joining us on the first part of the three-part series of the year in review. So this is a unique idea, the idea basically is that we are going to review the best papers in 2024. We are in December of 2024, so I say it's the right time to review all this, information which we had throughout the year. So the first part is we are going to tackle endocrinology. The next one, coming week, we are going to talk about obesity and metabolism. And then the week after that, we'll be talking about diabetes. So for the first part, just let me give you some, a few, basic idea of how we are going to do. So this entire thing is currently live streamed on our YouTube channel as well, which is Endocrinology India YouTube channel. And we are also live here. So we have, all the attendees will be able to see this live as well. We are also running a poll. So if you can see, on your end, you will be able to see a poll as well, where we asked a few questions. I'll allow you to, some time to answer the questions, right? We have already a few people who have answered this. So we have a poll or a quiz. The idea is basically to get some initial feedback of, what people are trying to do. Now, you can allow me to share my screen. So let me first start by introducing our guest today. So we have today with us, and it's a proud privilege to have Dr. Lakshmi Nagendra. Dr. Lakshmi is an associate professor at the Department of Endocrinology at the JSS Academy of Higher Education and Research at Mysore. Also, she has her own practice as well. So she's a consultant endocrinologist at Magna Centers for Obesity, Diabetes, and Endocrinology at Mysuru. In fact, you can see her achievements here, but I'll tell you, there are few people who are just gems, right? Who are like, who are just who have that energy, who have that force, their force of nature, right? And so Dr. Lakshmi Nagendra is a force of nature in endocrinology. I think one of the most promising endocrinologists of our generation. She has won the Pier Monier Young Scientist Award in 2024, a recent award. I think this is a very prestigious award, especially, in the field of endocrinology and bone research. She's the RSSTI Novartis Young Investigator Award, which was recently given to her in 2024 at RSSTI. She's also won the Endocrine Society of India Yuva Ratna. She has got an international travel grant from the Endocrine Society of India in 2023. And she was also winner of the ESI AV Gandhi Award for Excellence in Endocrinology Research. Okay. And she has keen interest, lot of interest in osteoporosis. So I'm sure in future, 10 years down the line, any osteoporosis article from India will have Dr. Lakshmi Nagendra, right? Without that, there's no more, research there. And she's also interested in systemic review and meta-analysis. You would have seen a lot of her meta-analysis being published in varied areas. We are going to discuss some of her meta-analysis as well today. So thank you, Dr. Lakshmi, for joining us today for this. This is the first part, and you are our opening batsman. So thank you for being part of this a little initiative of ours.
Thank you for that kind invite. And this is a great initiative. I learned a lot, while going through you've carefully selected a few papers which are going to make a difference in our practice and which have a lot of newer aspects to it. So thank you, sir, for this kind invite, and also, always learning from you. So I am mostly inspired by you. So thank you.
Yeah, thank you so much. And, I think also we'd like to thank our sponsors today. So we have Azadio, which is kindly agreed to, help us there. So there is no editorial, discretion from them. It's left to us, right? So we are, allowed to have our own completely, pharma-free editorial in that sense. Okay, so let's begin today. And what we are going to do is we are going to have a series of, articles and some very interesting research which has, which has been shown over this year. Again, just yet another little information. So we are collaborating this with technochronology.com, which is our online platform for learning. So if you're not done so already, you can go to technochronology.com and sign up. And there you will find this YEARMED article. So you can just go there, you can click on it, and whatever we're going to discuss, you will have the full summary and information there. We'll also have some quizzes over there, right? Some questions, the same, almost similar to the questions which are already flashing on a screen. So you'll find some questions there as well. You can answer that. You'll find more detailed information about the research that we are going to discuss. So you'll be able to access that as well, right? So how can you access that? You can directly go to technochronology.com, or this is the QR code. So you can use this link to join this course. Again, it's free of cost, so you can just straight away join. And the upcoming, the part 2 and part 3 also will be uploaded. All the information will be uploaded. So by the end of it, you might be having a series of about 20, 30 good research papers and summaries of them, which you'll be able to read in a jiffy and get the whole idea of how the endocrinology environment shaped in 2024. Okay, so let's first start with the first presentation. So this is what the entire thing will look like on technochronology.com. Okay, so let's start with the first question, Dr. Lakshmi. And we had this little poll question which you put up to our viewers. And we have about 76 people who are already logged in. So thank you all for logging in, right? And I think, thank you for being a part of this journey. So the question we asked, all of them is that this is a case scenario which you put up. So we have 35-year-old woman who presents to us with history of unintentional weight loss and palpitations. And we diagnose her as having Graves' disease. And you start her on carbimazole, and the patient wants to know whether, just like a lot of our patients, whether this medicine has to be taken lifelong. Okay, so is carbimazole a lifelong treatment, right? So the options we have given to our audience is yes, patient needs to take this medicine carbimazole lifelong, and the other option is no, Graves' disease is an autoimmune disease with the possibility of remission in a good number of patients. So 81% have answered no, Graves' disease, there is a potential of remission, and 19% have said yes, it's a lifelong medicine. So Dr. Lakshmi Nagendra, this is a prelude to our next, the article which we have discussed. So what's your view on Graves' disease? Is it a lifelong disease, or is it a disease with a finite duration of treatment?
Yeah, so this is a very clinically relevant question, and I'm sure we have patients who ask this question all the time, whether it's hyperthyroidism or hypothyroidism. The first thing they want to know is this lifelong? Do I have to take this tablet lifelong? So the first thing that I tell them that it's like Graves is not a lifelong disease in many people. Okay, so if you look at the life is like how the course of Graves disease is to be without any medications, like if you take how Graves is going to span out, so you can actually group patients into 3 categories. So the most common category of people would be patients who follow a relapsing and remitting course over many years. So over 50% of them fall in this category. Next would be patients who have a single episode of hyperthyroidism followed by a permanent remission, and this is as much as 40%. And then patients who have a prolonged continuous episode of hyperthyroidism, and those who never go into remission, this is 10%. So this is without any medication. If you look at how Graves is going to span out, you can actually categorize patient into these 3 categories. But then when you start on carbimazole, you have a good 40 to 60% of patients who can go into remission after 12 to 18 months of therapy. And this is also very important because I see some doctors advising surgery upfront or radioiodine upfront. Now, that is also not a good practice to do. Of course, we are going to talk about predictors of remission and all that. But I think every patient, unless contraindicated, should be given a trial of anti-thyroid drugs, simply because the percentage of remission that you're looking at is 40 to 60%.
Right. Great. So basically, I think it's a very important take-home message right at front that, Graves' disease is not something where, you may have to take medicine lifelong. There are chances in 40 to 60% where there are possibility of remission. And that's where that brings us to our, first article of today, which is a study which was published in the Journal of Clinical Endocrinology and Metabolism, JCEM. Now, for those of you who are new to this, JCEM is one of the highest rated journals in the field of endocrinology specifically, right? So it's from the Endocrine Society, and it's a very highly reputed journal, and it's a privilege for anybody to get published in that journal. So this study, which was titled as effect of low dose methotrexate with methimazole in patients with Graves' disease, and it was a randomized controlled trial. So what they did, something very simple. They took a bunch of patients with Graves' disease. Half of them, they gave them just the standard of care, which is carbimazole, or rather methimazole in this case. And the other group, they gave them methimazole. Along with that, they gave them methotrexate. I think so. That's an interesting, aspect of this treatment. So they had 153 newly diagnosed untreated Graves' disease patient, and they looked at one group which was just methotrexate, just methimazole. Another group was methimazole with methotrexate, and they followed up these patients in terms of the treatment outcomes. They also measured the TSH receptor antibody, which is called the TRAB antibody, and what we have noticed, as Dr. Lakshmi would agree, that when the TRAB becomes negative, there are more likelihood that the patient will remain in remission, right? So that's one of the good marker which you can see. Of course, in terms of achieving euthyroidism, both the groups achieved similar euthyroidism, because ultimately the euthyroidism was attributable to the methimazole, not to the methotrexate, right? But what they observed was that the group which was given methotrexate had lower TRAB antibody levels at 18 months, so there's substantial difference there, and hence there is more likelihood that they had, of course, remission and maintained remission. Having said that, there are of course concern that you're adding a new drug, whether there is a risk of having any complications. So there's no serious drug reactions with the low dose of methotrexate, that is 10 milligram once a week, that was given to these patients. So ultimately, and what this study has suggested is that probably methotrexate, this Graves' disease being an autoimmune disease, the methotrexate does some amount of immune modulation, regulating the T and B cell activity and reducing the TRAB level, and that is what ultimately leads to a higher rate of remission in this group, right? So the practical issue, and why we have chosen this article, because it's very important, because it can influence your practice. What they've suggested is that if you have a newly diagnosed patient with Graves' disease, you can consider adding methotrexate to that therapy, right? Now, we have one of our participants, Dr. Amitabh, who has raised his hand. Amitabh, you can ask your question, you can post your question in the chat, and we'll take up the questions in the end, right? So we'll allow some interaction as well, so we can take the questions at the end of the session. So that's the whole outcome, right? So now let's take some of the views of Dr. Lakshmi. And we already discussed this. Is Graves' disease a lifelong disease, which you gave a very eloquent answer. But let's talk about right at the front, right when the patient first comes to you, what are the markers and what are the things which tell you that the patient is more likely to go into remission, right? What kind of patients are you looking at in terms of possibility of remission?
So I think a couple of years back, the GRADE score has been validated for use in patients with Graves' disease. So you have 4 parameters in the GRADE score. So you have age, FT4 concentrations, and TSH receptor antibodies, and goiter size. So these are the 4 variables that you can calculate online. It's free to use. So there are 3 categories here. So you give points for each of it, and depending on the points that you get, so suppose you get 0 to 1 point, so there is a 16% chance of relapse. So if you get 2 to 3 points, there's about 45% chance of relapse. And if it's about the points you get are 4 to 6, I think there is about 70% chance of relapse. So the greater the score, the higher the chance of relapse. So this is a very good score to use, that I also use in my clinical practice to tell the patient, what are the chances of relapse. But the practical thing to do would be you measure a TSH receptor antibody upfront, and you start the patient on therapy, and then after 12 to 18 months of therapy, you measure TSH receptor antibody again, and if it is still strongly positive, it's unlikely that the patient is going to go into remission, right? It's still positive and will require therapy. So earlier, talking about medical therapy, earlier books said that you can use medical therapy only up to about 18 months, and then you have to go for radioiodine or surgery. But we are questioning that now. More and more data on long-term antithyroid drugs is also available now. So up to 14 years of antithyroid drugs have been given and studied, and it has been shown to be useful. But also if the patient has a larger goiter size upfront, like, at diagnosis, the goiter size is large, then the chance of relapse is low. So these are some of the variables which will tell us, but GRADE score is very good to use to quantify the chance of a relapse, yes.
Right. So I think it's a great point. So again, objective scoring system, can help you determine which patients are, but Dr. Lakshmi, if you see this paper, I think it's it's a great proof of concept, right? That there is a possibility of using other autoimmune, immune modulators for this disease. We started with methotrexate. Maybe in future, you might add mycophenolate or maybe some other immune modulators as well. We already know that in thyroid eye disease, there are role of other immune modulators, right? So do you see this any possibility of using other immune modulators in future from this proof of concept?
Yeah, definitely. The first thing I thought is, we are already using immunomodulators for Graves' ophthalmopathy. So I don't know why we were not, why I didn't think of this before. And if you go back and see, there are not many studies on this as well. This is like one of the very first studies that has studied this. Now we know that carbimazole also has some immunomodulatory properties, and that's why, we continue the drug even at lower doses. Even if the patient is euthyroid, we continue at the lowest possible dose for at least 18 months, just because of its immunomodulatory effects as well. So we've known this all along, but I don't know why we haven't thought of upping the game and adding another immunomodulator. I think this is a very important, very exciting prospect, and as we saw in the paper, many more patients achieved remission after treatment. So I think this would definitely be practice changing and would lead to more studies and studying more immunomodulators in Graves.
Yeah, so I think it's a very interesting idea. And we just take a couple of questions from the audience as well. So Dr. Arun Kedia has asked that, is there any role of, of course, it's not explored in the paper, but maybe in future, is there probably a role of increasing the dose of methotrexate, maybe, getting more likelihood of remission? Will that probably help?
So if you look at even Graves and the chance of remission, it is not dependent on the dose of antithyroid therapy or the duration of antithyroid therapy. So that does not determine it. So I'm skeptical if the dose of another immunomodulator would make any difference. So I don't think.
It may not be dose dependent, right? So it may be more of whether it responds to that or not. So maybe even a low dose respond and maybe a higher dose may not respond. So there is. And Dr. Amitabh Sur has asked, was there any difference in mean dose of methimazole between the two arms? So I'll say no, because they actually use the same dose. So they use a fixed dose only, 10 milligrams. So let me answer that. Dr. Arun Kedia has again asked that, so this is in a broad context, will a falling antibody titer suggest a good chance of remission in Graves' disease? Or does it suggest an earlier remission? So let's say you're tracking somebody's TSH receptor antibody, and if the levels are falling, does that mean that there are more chances the patient will go towards remission?
So I don't know. This is a very new concept because I've never, measured at intervals. We usually measure, at diagnosis and at 18 months. But this would be interesting to see if the rate of fall also is predicting remission. If somebody wants to know at 6 months if they're probably going into remission, then that would be interesting. But I have no practical experience with this because I've not measured it.
Yeah, makes sense. So I think it's a very interesting idea, Dr. Arun Kedia. I think, maybe potential a research topic, right? So maybe it can be considered for research. Of course, it's a little costly research because even now the, cost of this antibody is a little bit on the higher end of it. So serially measuring it makes it even more costly. But having said that, it's as an idea, it's probably a great idea to really consider. We have, we'll take some other questions in the end. Again, anybody who has a question, please don't raise your arm. My suggestion is just put it in the chat box, and we'll take the question as we go along. Now let's move on to the second article, which is equally, I think, interesting and practically relevant. So we asked this poll question before this. A lot of this topic has been in vogue for quite some time, right? There is a lot of interest in the area of primary aldosteronism. And, a lot of people, in fact, Dr. Korn, when he first gave the idea of primary aldosteronism, he said that, in fact, a lot of patients with hypertension have this problem, right? Which is under-recognized, which now we are realizing that it was probably right. So we all do this test, which is called aldosterone-renin ratio for primary aldosteronism. So we asked this question to the audience. Which of the following statements about aldosterone-renin ratio in the diagnosis of primary aldosteronism is correct? Is ARR has been consistently shown to have high sensitivity across all diagnostic studies, more than 90%. Is that true? Is it true that the positive ARR screening test alone is sufficient for diagnosing primary aldosteronism? Is it true that ARR threshold of 30 nanogram per deciliter per nanogram per ml per hour. So you're using plasma renin activity. With aldosterone more than 15, does it make is it an acceptable cutoff for this? So, I mean, of course, there is no correct answer, right? Just like, anything in medicine, but the most appropriate answer is C, which is ARR threshold. So 79% have correctly answered it, that a ARR threshold of 30 with aldosterone more than 15 and a suppressed renin is strongly diagnostic of primary aldosteronism. ARR alone is not sufficient. It's a screening test, so you have to back it up with a confirmatory test. And all studies are not shown very high sensitivity with ARR, but having said that, as of now, that's the best available screening test for practice. So, Dr. Lakshmi, broadly, what's your view on aldosterone-renin ratio as a screening test for primary aldosteronism? Just your general opening remarks on primary aldosteronism.
So ARR was very much emphasized before 2020, I would say. But if you look at the later articles now and also the newest edition of Williams, there is much less emphasis given to ARR. So ARR can be false negative or false positive in certain cases. Like, if you're looking at the ratio, even when aldosterone is like, say, 4, but if you have a suppressed renin because of some reason, you will still get a very high ratio, and that may not be very clinically relevant. So if you look at the newest edition of Williams or the later articles after 2022, where there is very much less emphasis on ARR, but a value, the more emphasis is given on the value of aldosterone, the absolute value of aldosterone if it is more than 10. And if you have a renin that is suppressed below the threshold, you can be using the renin activity or the direct renin concentration. If it is suppressed, then you are probably, looking at a probable patient of primary hyperaldosteronism. And of course, you have to do the confirmatory tests in there.
Right. Makes sense. So I think, one of the challenge, Dr. Lakshmi, as we know, is that when, traditionally, if you do ARR strictly as per the guideline recommendation, then you have to stop certain anti-hypertensive medications and you have to switch them to some other anti-hypertensive medications, which are not very pleasant, right? So you have to generally switch them to something like a prazosin or something, which may not be very pleasant for some of the patient because it has a lot of side effect profile, in that sense. So especially, patients on something like a ACE inhibitor, ARB, or these agents, or even a CCBs need to be stopped. That is what the traditional studies have shown. But this study, again published in JCEM, actually challenges this notion. So what they've done, it's a retrospective analysis. They've done something very simple. What they did is they measured the ARR while the patient was on the medication, whatever antihypertensive they're taking. They just measured that while they were on it, and then they stopped the drug and they measured the ARR again. Okay. And then they backed it with a confirmatory test. Those who screened positive, they did the confirmatory test. So then they skipped the middleman and they directly correlated the data with the final gold standard with the initial screening report, which was when the drug was not stopped, which makes it very simple, right? So in clinical practice, all you have to do is, without stopping the antihypertensive medicine which the patient is taking, directly send a aldosterone-renin ratio on treatment. And if it screens to be positive, then you do the confirmatory test directly. So which stops a lot of hassle which we have in clinical practice. And as you know, Dr. Lakshmi, you work both in private as well as in an institutional setup. And in private setup, patients, if you tell them that you have to wait for 2 weeks, 4 weeks, and change your antihypertensive medication and do this and all drama, they'll say probably no, I don't want this, right? I'm happy taking 4 or 5 antihypertensive medication which I'm taking, right? So that is often a challenge, because these tests are often more challenging to perform in real life. So this was the whole idea, right? So they did a retrospective analysis of about 1,300 patients. And what they found was that a cutoff on treatment of 0.7. Now here they are using direct renin concentration. They're not using plasma renin activity. So be careful about this when you're interpreting. Nowadays, a lot of labs are giving DRC only, but some labs may have plasma renin activity. So again, you need to see what data is your lab giving. And they found that this cutoff was actually without washout was actually very sensitive, 96.3% sensitive and 61% specific as far as the diagnosis was concerned, right? And they did a subgroup analysis also. So the sensitivity was higher in patients on beta blockers compared to those not on beta blockers. So if your patient is on beta blocker, just continue. In fact, it improves the sensitivity, right? That's something interesting. And so without washout, ARR is a good screening test for primary aldosteronism. It's a screening test, again, requires a confirmatory test with a good sensitivity and specificity. In a practical sense, what it tells you is that all you have to do is when your patient comes with hypertension, resistant hypertension, then what you do, and resistant hypertension is when you have 3 or more anti-hypertensive medications, including a diuretic. If your patient is that fits into that profile, and there are many patients like that, right? Just your diabetic patients, and they'll be, while we are focusing on their anti-diabetic drugs, look at their anti-hypertensive. They're already on triple combination of anti-hypertensive, and still their BPs are high, right? So such patients, it makes a very fruitful exercise to just measure the aldosterone renin ratio. If it's more than 0.7, you can send this patient for confirmatory test, for the testing and confirmatory test, right? So let's talk more about, primary aldosteronism in detail. And Dr. Lakshmi, can you just enlist what kind of patients do you screen for primary aldosteronism?
So this is a very tricky question. I'm guilty of screening. No, I'm guilty of not screening all patients for primary hyperaldosteronism. So if you look at the latest articles now, again, this is a very rapidly advancing field. And 4 to 5 years back, we were saying certain subset of patients need to be screened because the prevalence of primary hyperaldosteronism in hypertension was 5 to 10%. But now we have mounting data that it's close to 30%. And even in this study that we just spoke about, it was about 16.5% primary hyperaldosteronism. So earlier, there was a subset of patients, there were certain recommendations that you had to screen these patients. But nowadays, the recommendation is that you screen everybody for primary hyperaldosteronism. But that is not definitely possible in our country, especially in cost constrained settings. So at least a subset of patients who have a very, very high chance of having primary hyperaldosteronism, I try to screen. So that is obviously resistant hypertension. That is if your BP is more than 140/90 with 3 drugs, one of them is a diuretic, or if your BP is controlled with 4 antihypertensives, that is also resistant hypertension, and somebody is having hypertension and spontaneous or diuretic induced hypokalemia, that is also likely to be primary hyperaldosteronism. Or patients who have hypertension and an adrenal incidentaloма, definitely have to screen them. Or if somebody has a family history of primary hyperaldosteronism, first degree relatives, you have to screen them. But also very, very important to screen patients who have hypertension onset less than 40 and also have a history of a young CV. So they are also, very likely to have primary hyperaldosteronism. Having said that, I see most of my residents having this idea that, patients with primary hyperaldosteronism should have hypokalemia. And if they don't have hypokalemia, then that is very wrong. So very few patients with primary hyperaldosteronism actually have hypokalemia. So that should not be a criteria. So all of these are pointers towards, making a diagnosis of primary hyperaldosteronism or screening somebody for it. But the current guidelines say that, you should be screening everybody for primary hyperaldosteronism. And I haven't been able to do that.
Yeah. No, I think this it's a very important point, again, for the audience to really understand. Gone are the days when you only, so I think, the problem really, I'll tell you the history where it comes from. There was some edition of Harrison, which actually said this very particularly, that, if you have hypertension, and in the chapter of hypertension, that if you have hypertension with hypokalemia, it's very important to screen. And somehow it is stuck in everybody's mind that hypertension and hypokalemia, only then it suggests primary endo, which is not true. There are a lot of patients with primary aldosteronism not having hypokalemia also. So I think it's a very practical, important point. From the audience, we have quite a few questions on the issues of how to do the test and how to screen it. So I think it's a complex stepwise process. So I think what we'll do is we'll put the screening protocol as per the current guidelines on the technocrinology.com website. So you can maybe in a day or two check it out instead of us discussing in detail. So we'll put that up. And again, I remind you, all of you, please don't raise your hand. If you have a question, just put it in the chat box and we'll discuss that in due course. Now, you already talked about a lot of things in terms of your protocol for which patients you screen. Any specific protocol that you follow in your practice as far as primary aldosteronism is concerned, and any confirmatory test that you do in your practice?
Yeah, so before this paper, so thanks to you, I came across this paper. Before this, I don't think there was any paper that looked at, pre and post cutoff. So even I was stopping all the antihypertensives, or if somebody is on antihypertensives, told them, that, they cannot be screened. So I am guilty of doing all this. So, but I think after this paper, I'm going to change that. But so far, what we've been taught is like, if somebody is on, spironolactone, you have to stop that
Yeah,
for at least 6 weeks. So
yeah,
that was a must do. But for other antihypertensives which can interfere, like ARBs, you have to stop the drug for at least 2 weeks.
yeah,
So this was the thought, but now we are going to challenge that. But it's also very important to make sure that if the patient has hypokalemia, that's corrected before you do an ARR. So that
right.
is something that most of us go wrong. So if the patient has hypokalemia, so that's going to lead to a lot of false positives, or false negatives. So you have to make sure that the patient's potassium is corrected, and also on the day of testing, the patient has to be ambulant and seated for about 15 minutes, after which you draw the blood sample. So the posture and the positioning is also very important. And after that, you draw the ARR, of course, keeping in mind some of the drugs that can interfere. No, so if somebody has had a hypertensive crisis and CVA, it's impossible to stop all of these drugs, right?
Right.
Especially if you're
Yeah.
stopping, mineral corticoid receptor antagonists, that BP is going to go up. But example, okay, so just I'm going to get to that. But when you talk about the protocol, so this is what we do
Mm.
upfront. You do the aldosterone and you do the renin. So the current guidelines say that if your plasma aldosterone concentration is more than 10, and if your plasma renin activity or your direct renin concentration is less than the lower limit of normal for the assay, you have to investigate for primary hyperaldosteronism without much emphasis on the ARR. Okay, so but ARR is also good, the cutoffs that you said. I see a question on the chat box if you can convert the
Mm.
PRA to DRC. So the DRC cutoff, so most of the labs that that we use now are giving DRC cutoffs. So the DRC cutoff, when you're using the the ratio is 2.5. Which
Mm.
corresponds to the 30 PRA that we're using. So the ratio there would be 2.5. I've not seen what 0.7 here corresponds to PRA, so that is something we'll have to calculate and maybe
Yeah,
pick up later.
yeah,
But as a cutoff to screen for primary hyperaldosteronism, if you're using the direct renin concentration, the ratio, the number to use is 2.5 for the ratio. So after,
that's
so after this, if the numbers are above the cutoff, then you do the confirmatory test. So the easiest confirmatory test to do, and something that most of us do in our practice, is the saline test. So you give normal saline for 4 hours. So you give 2 liters of normal saline, and post that you again test for the aldosterone concentration. And if the aldosterone concentration is more than 10, then that is definitely suggestive of primary hyperaldosteronism post this saline confirmatory test.
okay. Excellent. I think you've covered this beautifully. You covered all the points. I think you have Venkata Rakesh. I'll just answer this question. So just to clarify, what this paper is suggesting is that you do on the treatment, you do ARR. And then if it's more than 0.7, then you go to the confirmatory test directly. You don't have to stop it and then do it. Because they are showing very high sensitivity. So when you have this high sensitivity with the existing, then there's no point of stopping it and then doing it again. So just directly you can move to the confirmatory test. That is what they've suggested, from this paper. So I think that's a great idea, and I think it's a potentially practice changing. Amitabh has asked about how to avoid AVS. I think we can, Amitabh, we can discuss this in person later. Okay, and yeah, I think this you already answered. What were the cutoffs before ARR was, before this study? So you already answered this. So yeah, so then let me just go to a little thing which we have done. Now, this is something, Dr. Lakshmi, I think we discussed in one of the other meeting the other day. This is something which we have been doing. And that idea is that when you have a paper like this, or when you have some important information, why not convert it into a usable calculator, right? So what we did, we actually made a little calculator. This is available on technology.com. So this is based on this current research, right? So what you do is you take your lab reports, you take the aldosterone and the the direct renin concentration, because maybe 3 weeks down the line or 4 weeks down the line, you will not remember what cutoff there was. So you can just go to this little calculator and then add the data, and then just it will give you the result, and it will tell you whether it screens positive or not. And also tells you the next steps which you should consider doing, and also tells you the study performance matrix, right? So sensitivity, specificity at that point, right? So I think which is a great useful asset for you. So you can try this out. And for a lot of people who have asked about using different cutoffs and different tests, we have another thing called endodynamic. I'll probably put the link later in the module as well. So you can go there, where we have made a module which I actually personally use for my practice, and I just put it up for others to use as well. So where, because some labs do a plasma renin activity and some labs do a DRC. So we have made it for both. So whatever lab you're using, you enter that data and it'll give you whether you're screened positive or not. So you can put that up. I'll share that in due course in the module as well. So just, I'll suggest maybe in a couple of weeks, you can go back and check the technocrazy.com maybe before the next session. And then there will be some more material we'll put up there as well. Now let's move to the third article. And I think this is not a study itself, but this is a proof of concept. But this got a lot of, Dr. Lakshmi, got a lot of rave reviews in some of the conferences. One of the reasons actually probably comes from eminence-based, endocrinology, which is basically, this is Ralph DeFronzo's concept, which that's why it got a lot of traction. It's not a study, it's a proof of concept, and they're actually doing a study here. And it's a great idea. So what they're doing is, it's called a catalyst study. So it's basically hypercortisolism in patients difficult to control with type 2 diabetes, right? Now, the idea is, so simple idea, that you have patients with difficult to control type 2 diabetes. And in such patients, you screen them for Cushing syndrome or subclinical Cushing syndrome, rather, right? So that's the whole idea. So this is the idea. So you do a 1 mg overnight DEXA suppression test in patients where you have poorly controlled diabetes. Right? You can read the paper in more detail to see what the exact definition of poorly controlled diabetes they put. And then what they want to see is that, whether they're asking two questions. So one is whether they screen positive for subclinical, hypercortisolism or subclinical Cushing's. Secondly, they also want to do treatment on this. Now, one of the treatment for such patients is actually mifepristone. So what they're suggesting is that if they screen positive for that, why not give them mifepristone, right? That's the whole idea. And that is what they will be looking at. And mifepristone dose 300 milligram daily. Remember, mifepristone is available in India as basically a pill for abortion, medical termination of pregnancy. It's not available for Cushing's in India. But of course, this is off label in India, but in the US, it is available for this particular indication. And then they want to see whether, mifepristone is helpful in such patients. Now, this is again a proof of concept. We don't know the results because the study is not yet done, but it's an interesting idea. The reason why I put this up, because two reasons. One, it got a lot of traction in a lot of, international conferences. Secondly, it's a very good idea, right? So maybe think of that as an idea. So again, overall, what they are saying is that difficult to control type 2 diabetes patients, you screen them for subclinical Cushing's, and if found positive, consider mifepristone for such patients as an anti-diabetic agent, right? So, Dr. Lakshmi, wild idea comes from Ralph DeFronzo, who is known to have wild idea, but also is known to have wild ideas which actually work. So what is your overall impression of this entire idea as a concept?
So if you look at it, we've been using, this drug in Cushing's, and then all the studies are showing that the glycemic control is better with this. So again, we've been using it in some other context, but this is a bright idea, but not so old if you look at it. We've been doing it, but I was confused when I first read the paper, because these are not patients with Cushing's, right? You are excluding patients with Cushing's.
But you're excluding patients with Cushing's. So it's basically difficult to treat type 2 diabetes.
Type 2 diabetes. So the etiology of cortisol secretion in them is a little bit tricky. So they can be having autonomous cortisol, secretion, not Cushing's, but cortisol hypersecretion. But also, will it work in chronic stress? Like, when we speak about cortisol levels, what are we defining it? Like, that's very important. Are we, using it we know that, chronic stress can lead to cortisol excess, and, it can also have the impact on glycemic. So it's not very clear at the moment how we are going to, define hypercortisolism.
Yeah, but they're doing a DST and they're using the standard cutoff. So they are doing your overnight DEXA suppression test. So basically, then they are, in a sense, trying to detect autonomous secretion of hypercortisol. So what I really find interesting is that then if you have this positive, if you screen positive, why not do the whole way and actually screen the patient for Cushing's completely, right? Maybe find a, just like primary aldosteronism, maybe find a treatable cause of type 2 diabetes, right? So I think that's where I think it falls a little short. But as a concept, it's a great idea. And again, Dr. Lakshmi, as a broad idea, we have a lot of these crosstalks between various hormones, right? And that's what makes endocrinology very fascinating, right? So what do you think is the crosstalk of cortisol with metabolic syndrome? Because you know this pseudo Cushing's, right? This patients who look Cushingoid, but they don't have Cushing's. They have pseudo Cushing's, but they have all the features, and they have clinically they will be sleep deprived, maybe even have metabolic syndrome, they'll have chronic stress, they'll have depression, these kind of patients. So what's the crosstalk between cortisol and metabolic syndrome overall?
So we know that cortisol has its effects on various components of metabolic syndrome. It has effects on insulin secretion, also on insulin activity, can lead to insulin resistance, also fat redistribution. Now, this is all proved, and we have many studies which show that it is. There are studies which are looking at hair cortisol levels and correlating with metabolic syndrome. But I came across a recent systematic review and meta-analysis, the most recent one, which looked at 8 a.m. basal cortisol levels and looked at various components of metabolic syndrome. And they said that, there is no correlation between this. It's not associated with, cortisol. So I think it's still a very gray area, so to say, there is contradicting information, whether it is, whether it really happens, whether it's transient in, periods of stress, or whether there is really, a permanent sort of thing to it with autonomous cortisol secretion, whether we need to be doing this in all patients with uncontrolled type 2 diabetes. I would say it's still evolving. And this is a very exciting idea to think about.
All right, so it's a great point. Let me just see if there are any questions on this. Yeah, I think there are a lot of questions on the previous topics. So I think we'll come back to that in the end if we have more time. And to Dr. Anish and all the things, like I said, we'll put up the standard protocol as given by the current guideline of primary aldosteronism on the technochronology.com module. So you can check out the, and the other, questions which you have about, sample collection, all that. We'll put that up soon. Let's then move to the article number 4. And that was about testosterone and fractures. And I think this falls right into the domain expertise of Dr. Lakshmi Nagendra. It's a very interesting paper. It is published in NEJM, extremely controversial. This had to be in a year in review. It would have been a great, disservice if we are not included this paper. It's a negative study, but yet very interesting. So it looks at testosterone treatment and fractures in men with hypogonadism. This was published in New England Journal of Medicine. And the idea was, the one-line summary is that, so let me just go to this, right? So idea was very simple. They took transdermal testosterone and gave it to men with hypogonadism, and they wanted to see the outcome in terms of the, risk of fracture. And they took about good number, 5,200 patients between 45 to 80 years with proven hypogonadism, whatever the etiology. And they looked at the, they gave them transdermal testosterone, and they looked at the fracture outcome, right? So this was the overall, idea of the study. What they found was, contrary to what was expected, exactly opposite to what was expected, testosterone therapy actually increased the likelihood of having fractures, right? Contradicting what was earlier known from studies. And of course, there are a lot of limitations in this study, which Dr. Lakshmi will dissect. But overall, as of now, so I remember, Dr. Lakshmi, when we discussed this before the event, that when I was a resident back in the day, we were taught that if you have a male with hypogonadism and osteoporosis, you treat the hypogonadism, don't treat the osteoporosis. But now that is clearly challenged, right? So that you don't just treat the hypogonadism, you have to give osteoporosis treatment as well, right? So you have to consider giving that as well. And that is what I think a very important message which comes, that don't just treat hypogonadism. That's not enough. If they have osteoporosis, you have to treat the osteoporosis also. But this is the paper. It's freely available on NEJM. But questions. Are you surprised by the result? And what's your overall view on this? I'll give you the stage. This is all yours. I want to speak your expertise on this topic.
So, like we discussed just before, so this is the controversial paper of the year, something like, made us, stop what we are doing and take notice, this paper saying that means that, you don't give testosterone to men who have hypogonadism. So this is quite controversial, and also they said fracture. So it's very important to remember that the fractures that were increased in the study are not fragility fractures. So all types of fractures were increased, and if you look at the paper, the types of fractures that were mostly reported were ankle fractures and rib fractures. So ankle fractures and rib fractures are not typically osteoporotic fractures, not fragility fractures. They are mostly trauma related. So, and also when you look at the fracture curves, okay, so when they are diverging from the placebo and the testosterone trial is early in the course of treatment. So somebody who has hypogonadism and you start them on testosterone therapy today, they were likely to have a fracture in this early course of treatment, like in the first 6 months. Now, what does that say? So when you look at it, so when you start treatment with testosterone, the behavior of these men is going to change. So they are going to be more mobile, they're going to be more active. So that could have explained the traumatic fractures that increased in this subset of patients. So that is what was postulated. But again, this study was not designed to study the activity or whether they were fragility fractures. And also, these were self-reported fractures. So it was over a telephonic conversation that the investigators called the study subjects and asked if they had a fracture, and it was noted as yes. They did not ask about the mode of fracture, whether it was from a trivial fall, trivial trauma, whether they had significant trauma that could have caused these fractures. But even when you look at the type of fractures, they were not fragility fractures. That being said, I looked in detail at the paper to see if fragility fractures were different, and surprisingly, even that was not. So even major osteoporotic fractures and hip fractures, which are usually fragility fractures, were not different. So at least they were not increased in the testosterone arm. So what we can say is fragility fractures were not different between placebo and the testosterone arm, but definitely there was an increase in traumatic fractures in the testosterone arm, the reasons for which we have discussed. But if you look at the paper per se, they say that, they were also surprised. They write in the paper that they were also surprised by these results, and they did not expect this, and therefore did not, design the study to look at why this happened. So they were, postulating that maybe it is leading to some changes in the cortical microarchitecture of the bone, which could have led to this. But I don't think that is, possible here. If you look at previous trials of testosterone and bone mineral density, we have many trials that show that with testosterone, your bone mineral density improves. Now that, that is proven already. And in this trial, we did not look at bone mineral density. So it was not studied at all. So it was just fractures. So if they had looked at bone mineral density, I think that would have shown an improvement. Okay, so there was no data on fractures before this study, and everybody was waiting for this study to throw some light on the fractures. And unfortunately, they did not specify the type of fractures, and it turned out to be quite controversial. But when we look at testosterone and BMD, there's no doubt that BMD does show improvement with testosterone. But when you look at fractures from this trial, what you can say is that osteoporotic fractures are both same in both the arms. So probably just giving testosterone is not enough for these patients. You have to treat with testosterone, but also you have to consider anti-osteoporotic medications in them to prevent fractures. But another important point from this trial is that if you are, treating a man with hypogonadism, you do not start testosterone only from the bone point of view. So you're also going to look at his cardiovascular health, his sexual health, and also his bone health. You're going to take all three of them together, and when you're considering whether this man should be started on testosterone or not, and not just the bone aspect of it.
Yeah, that's a great point. I think that was exactly what we asked in our the quiz also. So you have a 62-year-old male patient with documented hypogonadism and high fracture risk presents to the clinic. His T score is minus 2.6 at the femoral, and there is a history of vertebral fracture already. So he's a high risk patient. According to the guidelines, which is the osteoporosis in men guidelines by the Endocrine Society, what is the most appropriate treatment approach for this patient? So is it just testosterone replacement alone? Is it bisphosphonate therapy alone? Is it calcium and vitamin D supplementation alone? Or is it testosterone plus an agent with proven anti-fracture efficacy that is, depending on whatever agent that is? 58% gave this answer, which is the correct answer. So as Dr. Lakshmi Nagendra rightly said, if you have a male with hypogonadism and osteoporosis, you have to treat both the hypogonadism and the osteoporosis, right? So you have to give some treatment for osteoporosis in itself, right? And again, testosterone alone cannot be given to patients just for the bone perspective. I think that's a very good underlying message which is there. I think that's again a practice changing aspect of this. And Dr. Lakshmi, in general, what is an approach to a male with, in brief, a male with osteoporosis? We have a patient coming, and a lot of these patients, we discuss over time. Somebody does a DEXA and some sort of routine screening in some camp, and then the patient lands up in your OPD. What do you do with such patients?
So it's the same as women, how you screen anybody else. It's nothing different. So what I do is I use the FRAX first. So I'm a big fan of FRAX because we can't do BMD in all our patients. I screen first with FRAX. And if they are in low risk, then I don't go to do a DEXA at all. But if they are in the medium or high risk, then I do a DEXA. And based on the results from the DEXA, if the T-score, again, T-score is the standard that we use even today, even with all of its limitations, we use that. And if the patient has osteoporosis or if, osteopenia with a FRAX score above the age threshold, then I treat the patient for osteoporosis. And if the patient has a concurrent hypogonadism, then I look at the other aspects also that I mentioned, his cardiovascular health, his, sexual health, along with bone health. And if he does, if there is testosterone therapy warranted in such a patient, then I start testosterone along with anti-osteoporotic medications. And of course, optimize calcium and vitamin D. And something that we all forget is, resistance training, like resistance exercises in these patients and fall prevention.
Great points. So I think, again, quick question. What's the best way of replacing testosterone and hypogonadism in your opinion? And what does the data suggest?
So I have used only the injections. I have had, I've not had access to other forms. But transdermal is, better to use injections because you don't have the, side effects associated, especially pulmonary embolism and all of that. Right. It was good, but I don't have access to it.
Yeah. Okay. So it's available in India, Dr. Arun. We have transdermal available in India, though it's a little pricey, expensive. They're available as gel. It has to be applied daily. But it's a little bit on the pricey side, and you have the long-acting depot injections as well. And you have the slightly medium-acting monthly injections as well. So you have a variety of available agents. As far as data is concerned, and as you saw from this study, I actually looked at transdermal because in the West, transdermal has become most popular. And I think, Dr. Lakshmi, I think you're trying to answer that. I think that's a great question. Can we conclude that increase in BMT doesn't always decrease the fracture risk post this?
Like, if you look at most of these studies, this is something that I've, realized over time. So these are different outcomes. So increase in BMD and fractures are different outcomes. So most of us study in our short-term studies, we study increase in BMD, but we don't know the effect on fractures, especially the 10-year risk of fracture, we don't know. So yes, the increase in BMD is not always equivalent to a decrease in fracture.
Yeah. So I think it's a great point. So you see, these are chance events. So fracture is a chance event, right? Remember that. So I think both are important, have correlation, but does not mean that both are equal parameters, right? So I think that's a great idea. It's like having a risk of stroke and a stroke itself, right? So which is, I think, some idea. So quick review. Now we are going to do, Dr. Lakshmi, of some of the newer drugs in endocrinology which were studied this year. And what is interesting, and again to the audience, some of these papers are by Dr. Lakshmi herself, I think, which is great. So we have crinecerfont in congenital adrenal hyperplasia. Now, this was studied in both adult as well as pediatric. Both of the papers were released this year, and this has been found to be very useful and reduces the requirement of glucocorticoid doses in both adult and pediatric patients with congenital adrenal hyperplasia. Then you had the infigratinib, which was used in children with achondroplasia, and that was another study. And then there are two papers from Dr. Lakshmi, who looked at did a systemic review and meta-analysis of levoketoconazole and osilodrostat in Cushing syndrome, right? All tongue twister names, right? It'll take a few years for us to kind of get it in our vocabulary. So quick questions about these. First, let's start with your papers and your we have the papers on the module, so you can read the papers as well as look at the original papers as well. In general, the two drugs for Cushing's, what are your views on these two drugs, and what are these drugs, and how do they act, and what did your study find?
Yeah, so these were two new exciting drugs in Cushing. So we had, on levoketoconazole, we had two trials, the Sonix and the Logix trial, on which we did a systematic review and meta-analysis on, and there's also osilodrostat. So speaking about levoketoconazole, first we know that, levoketoconazole is the purified, the 2S4R enantiomer of ketoconazole, and is currently actually approved. The FDA has granted its usage in Cushing syndrome. It's used in a dose of 300 to 1,200 milligrams daily. So the idea with using levoketoconazole over ketoconazole is because of its, lesser incidence of side effects, especially hepatotoxicity. So transaminitis is still, very important side effect with this drug, but the incidence is thought to be lesser. So what we found out from our meta-analysis is that patients on levoketoconazole for Cushing's compared to placebo actually had the urinary free cortisol was measured, and many patients achieved normalization of urinary free cortisol as compared to placebo. So levoketoconazole was a good drug as compared to for use in Cushing. So it established the safety and the efficacy of levoketoconazole in Cushing's disease. Now we know that osilodrostat, again, another new drug, another exciting new drug, and this is actually approved by the US FDA and the European agency as well. So CYP11B1 and 11B2 inhibitor can be used in Cushing. So this, again, we saw the patients with Cushing's who are having a normalization of urinary free cortisol, and patients with osilodrostat, as expected, had, the greater number of patients with osilodrostat had normalization of urinary free cortisol, again to establish the efficacy of osilodrostat in Cushing's disease.
Yeah. Very interesting. And about the crinecerfont, which was a drug used in the congenital adrenal hyperplasia. So what do we know about this drug, and what do these
we know
papers?
That just to give a brief recap about how this drug is actually acting. So we know that CAH, we have the production of cortisol is affected, and there's no negative feedback, and that's why we have excess ACTH, and then that's acting on this steroidogenesis pathway, and then we have excess of androgen precursors, androgens especially. So this is leading to precocious puberty in males, or it ambiguous
hyperandrogenism in female. Yeah.
So we are looking at manifestations of hyperandrogenism. And now the current standard of treatment that we're giving is we are giving glucocorticoids, right? At supraphysiological doses. So it's very important to remember that the glucocorticoids that we're giving now are not at physiological doses, but because we want to suppress this ACTH, we are giving at supraphysiological doses. And this supraphysiological dose of glucocorticoids, as we know, leads to a lot of side effects. It could be, Cushing-like state, it could be osteoporosis, it could be diabetes, it could be hypertension. So it comes with a lot of side effects, and we want to reduce the dose of glucocorticoids if possible. So that is where this drug comes in. So crinecerfont is a CRF1 receptor antagonist. So it's acting on the CRF. So corticotropin releasing hormone is, the release is affected here. So then it's not acting on the ACTH, and the ACTH comes down. So we don't have the harmful effects of hyperandrogenism that we were talking about. So because we are, targeting the ACTH through another pathway, the dose of steroids comes down. So this was studied in both adolescents and adults. I think in adolescents at 50 mg BD and adults at 100. They were four subgroups, but 100 mg BD was one of them. And in both adults and adolescents, it showed lower levels of androgen precursors, but also it led to a reduction in the glucocorticoid dose.
So again, to make it clear to the audience, and I think it's very well explained by Dr. Lakshmi. So you have two aspects of treating CH. One is to give supraphysiological doses of the glucocorticoid to basically suppress the ACTH production so that the androgen precursors, the precursors which are there, which lead to hyperandrogenism, are suppressed. That is one. Secondly, you also, because they don't have cortisol in itself, you have to give replacement doses also, right? Now, since you're giving supraphysiological, you are embedding the replacement dose also within it. Here, what you're doing is you're separating these two aspects. So the suppression aspect is left to this drug. And then what you're left with is just the replacement aspect of it. So you'll still need steroids. It's not that these patients will not need glucocorticoids. They will need it. But they will mainly at some point of time only require replacement doses, physiological doses, and not for supraphysiological doses, which spares them from the side effects of the steroids also on a long run, right? So because a lot of these patients, if you see Dr. Lakshmi in practice, we see them that they become Cushingoid, right? We are very difficult to really give them the right dose, so it becomes a big challenge, and they, if I think a well-managed CH, when I think it's a great job done by, the endocrinologist. I think, when you see the patient otherwise looking normal, that's great job. It's very difficult to achieve. And then we have this new drug for achondroplasia, right? Achondroplasia, it's an orphan drug. I think not many people have really ventured. It's a great study. It's great, I think, service also to mankind in a sense, So we have infigratinib, which was studied in achondroplasia. So can you tell us a little bit about this drug?
So again, looking at the pathophysiology of achondroplasia, so we know that FGFR3 mutation is leading to this condition. So we have downstream pathways after the mutation, the MAP kinase pathway and the STAT pathway. So these are leading to the manifestations of the FGFR3 mutation. So this so before this, we don't have any oral drug that can treat this condition. So this is the first oral drug which is introduced in achondroplasia, which is studied. So infigratinib is an orally bioavailable FGFR1 to 3 selective tyrosine kinase inhibitor. So this actually acts on the FGFR and then the downstream pathways that I spoke about. So that is taken care of by this drug at the very pathophysiology. So we don't see the manifestations of achondroplasia. So in the trial that we are talking about, this drug was given and the growth velocity was studied, and it was better with this drug, which is very heartening to see because there was no oral drug so far. So one consideration was hyperphosphatemia, which can happen because you're blocking the FGFR. So hyperphosphatemia, very surprisingly, was seen only in one patient, and it was also very transient and could be managed with reducing the dose of the drug. But it was not of concern. So when you think of the pathophysiology and you think of a drug blocking that, the first thing that you think, hyperphosphatemia can be a concern, but surprisingly, it was not. Yeah.
Okay, great summary. Let's then move to the last paper of today, which was, I kept the best for the last paper. It's an Indian study. So you have this study from the KEM group, Dr. Robin Garg and Sabha Menon. And they looked at overnight 1 milligram DEXA suppression test in various stages of chronic kidney disease. And they actually generated a normative data and of the underlying mechanisms. The idea was, so it's a very simple idea. But great clinical use. So the challenge is that when you're using 1 milligram overnight DEXA suppression test, they are all made for patients who are having normal eGFRs. But what if your patient already has chronic kidney disease? Then what cutoffs would you use, right? So that was the whole idea of this, thing. It's a fascinating paper. They looked at the normative data at various eGFR cutoffs and also gave suggestions as far as, and in fact, they went a step ahead. They looked at the dexamethasone bioavailability at these, various eGFR cutoffs. They also looked at certain other clinical markers as well. So I think overall, it's a very well conducted study, and I think it's a very useful normative data, and I think it's a great service which these guys have done as far as the clinical practice is concerned. The practical idea is that you need to use EGFR based cutoffs for ONDST, overnight DEXA suppression test. And also again be aware that you look at the essays also, and the because they actually looked at different essays also in their study. So I think that makes it a very useful thing. Now what we have done again, we have made a little mini app or a toolbox which you can use. So again, what you need to do is just go there, enter the you don't even need to calculate the EGFR. It will do that for you. So enter the data: creatinine, gender, age of the patient, the cortisol level of the patient, right? After overnight DEXA suppression test. You can also mention the assay which you are going to use in your in your lab, and then it will tell you whether the patient screens positive for Cushing's or the patient does not. I'm sorry. And also there is also a lot of optional other optional data from the study, so which we also kind of included. But the other baseline cortisol, ECTH values, serum dexamethasone values also, these are optional. It calculates the EGFR, tells you the EGFR category, and then tells you based on the cutoff whether the patient has Cushing's or not. So I think that's something you can use in your practice if you find it useful. That is based on this paper. Now, Dr. Lakshmi, what do you think about this paper? I think, and great. I'm sure you'll agree it's a great service. So, what are your views on this recent research from India, and is it going to be useful in your practice?
Of course, I mean, it's so heartening to see this paper published in the prestigious JCM, and we know all of them. So we know Sabha, so they are our colleagues and friends. So it's quite, it's very nice to see this paper. And also this, reminds me that, we don't have a lot of normative data from India.
Right.
So we a lot of data on some exquisite conditions and all of that, but what we lack is normative data and also epidemiology. So I think these are the two areas that we have to work on when we speak about research from India, and this paper has done great. And if you look at the cutoff, so it is ranging from 1.2 in healthy volunteers and goes all the way up to 7 in CKD stage 5 on dialysis. So when you get these cutoffs, it just changes your practice, because before this, I don't know what I'm dealing with. It's somebody with CKD stage 5. How do you screen, and what are the values? What do you interpret this as? So nobody knew how to interpret this. But I think this study, did a great job by throwing some light on it, and very innovative, and makes me very happy. Yeah.
Yeah, so I think it's a great point, and I think Dr. Lakshmi, if we'll just take a couple of few questions from the audience, since we have time. And this was the last paper of today. We have, so I think we've done a good job in terms of getting a whole overview of how endocrinology is shaped this year. But we have some more questions from the audience, and I'll just there's one recurring theme, so I'll just pick up some recurring themes, before we wrap this up. One is that use of selenium, and there's a couple of questions on that. When we talked about methotrexate as an immune modulator, there are quite a few questions on whether selenium is something which is useful in terms of potential immune modulation in Graves' disease. We already know that it is useful in, again, thyroid eye disease. Is it useful in remission? Of course, we don't have much data, but again, as a sort of overview and expert opinion from your end, what do you think? Where does selenium stand?
So, I mean, this has given me a new research idea. Actually, this question has given me a new research idea. But before this, when you talk about selenium, I think we are talking in context of, these supplementations and people who don't want to take any medication for their, thyroid disease. So they want to take selenium. So I want to make it very clear that, selenium is not the substitute for anti-thyroid drugs or your levothyroxine, but can it be an adjunct is something that we have to.
Interesting. So it's an interesting idea. I think maybe Dr. Lakshmi, as a research idea, because since you use that as a early, in early thyroid eye disease, I'm sure there are a lot of people who would have used it, and there'll be a lot of data on that also. Maybe we can see in a sort of a retrospective analysis whether amongst these studies whether there are more chances of remission. Maybe that will give us some clue of whether it's something useful in terms of just Graves' disease itself. So I think it's an interesting idea, and again, interesting research work for future. So I think we end here. Dr. Lakshmi, thank you so much. I think you have been fantastic. I think again, we got very good positive in the questions itself. We got very good reviews, which is great. So thank you for being a part of this. I think you've covered everything beautifully. I think you've kind of given us a great overview of the topic in itself. So thank you so much for spending your evening for this exercise, of doing an year-end review. And those who are interested in, we are continuing the series. Next, we are going to have Dr. Tejal. Dr. Tejal Lathia is an endocrinologist from Mumbai, a great friend of ours. She's going to be with us on next Tuesday, not Wednesday. So we're going to have it next Tuesday at 8:30 p.m. Where we're going to discuss about year-in review about obesity and metabolism. So I think it's a lot in, and in the next upcoming year, you're going to see a lot of endocrinology being involved, with the hands dirty with obesity. It's a very important area for, the next year. 2025 will be obesity year for endocrinology. So I think it's going to be very important. So I think this is an important area which you want to learn. So if you are interested, we'll put up the links as well, and you can use this QR code directly to register, just like you did for today's session. And we'll be doing it year in review. A lot of GLPs we are going to talk about. So, stay tuned for that. So thank you. And once again, thank you, Dr. Lakshmi, for this. And any final comments and any other points you'd like to kind of put in?
I would just, want to thank you for kind of handpicking these, studies. I had missed many of them. So this, is a quick review for me as well. So about all the things exciting in endocrinology that happened in 2024. So thank you for this opportunity. I read through a lot of interesting stuff and came across papers that, I otherwise would have never had the chance to look at. So thank you, Dr. so much.
Thank you, Dr. Lakshmi. Thank you once again. And I think for again, those who joined in late, Dr. Lakshmi is a clinical endocrinologist practicing both as an associate professor and as a clinical practitioner in Mysore. So again, very prominent name there. So and a lot of papers. So read up her research work. I'm sure she'll be very happy when you read her research and give her feedback on her research, because she's doing a fantastic job in this field. So thank you once again, and thank you all for being a part of this. Again, thank you to Azure Duo for sponsoring this. Like I said, there is absolutely no editorial control for them. It's all independent, right? From any sponsorship. But thanks to them for providing this entire platform for us to have this session. And once again, have a pleasant evening for all of you, and good night. And see you next week for a session on obesity. And thank you, Dr. Lakshmi. Thank you. Good night.
Thank you. Good night.
Good night.